Well, good day everybody. This is Chris of the Ancient Scholar. I hope this video finds you all doing well. I find myself working another weekend at my other job, doing some nights. Just kind of got the nightly rush of people taken care of, and I have just a little bit of time, so I thought what I'd do is talk a little bit about what I think to be a fairly important, or has a potential to be a fairly important clinical trial that impacts emergency medicine, critical care, and even pre-hospital care. And that is the results of a trial. This is a clinical trial that's looking at cardiogenic shock, and we really need a win here. There have been some contemporary studies that have looked at intra-aortic balloon pump, or IABP, as well as ECMO, and the results have been, shall we say, disappointing, to say the least. And so over the last decade or so, a Danish group, the trial's sponsored by the Danish Heart Foundation and AO Biomed as well, I guess we should say that. And it's been going on for about 10 years, and the results and analyses were finally published in the New England Journal of Medicine on April 7th, 2024. And the name of the study is Microaxial Flow Pump, or Standard Care and Infarct-Related Cardiogenic Shock Microaxial Pump, referring to the Impella. This is also essentially referred to as the DanGer shock study in the vernacular sense. Authors Jacob Muller. I'm not sure if I'm pronouncing that. This is a Danish name, but it's Jacob Muller et al. So what I thought I'd do is talk a little bit about the trial and give you my take on it, because it is compelling, but maybe not in the way we all hoped. So the description of the trial was to compare the safety and efficacy of the Impella versus standard of care. So essentially your general standard of care for cardiogenic shock, pressor, supportive care, revascularization, etc., versus standard of care plus Impella, and kind of look at how things went in both groups of individuals. The design, patients were randomized in a 1-to-1 fashion. They either were randomized to the Impella plus standard of care or standard of care group. Sounds pretty good so far, right? In for Impella plus standard of care is 179. In value for standard of care was 176. So a total of 355 participants were ultimately enrolled into this trial in 10 years. Interesting. So a total of just over 1,200 were screened, and there's a fairly lengthy list of exclusion criteria that I find kind of interesting. So a fairly significant number of those 1,211 to be exact, 1,211 participants were excluded. And so some of the significant exclusion criteria, I'm going to go over these. Some of these make sense, and others I kind of scratch my head at. So shock duration greater than 24 hours. So if they were in cardiogenic shock for greater than 24 hours, they were excluded. Other causes of shock like sepsis, hypovolemia, etc. were excluded. That makes sense. Shock due to mechanical complications of the MI, so papillary muscle rupture, rupture of the ventricular septum, ventricular free wall rupture, that all makes sense. Severe aortic valve regurgitation and or stenosis, again that makes sense. Severe peripheral arterial obstructive disease, that would preclude Impella device placement, that makes sense. That's going to impact the placement of any kind of mechanical circulatory support device like a balloon pump. Mechanical aortic valve prosthesis, already established mechanical circulatory support such as being on ECMO, left ventricular thrombus, infective endocarditis, shock due to a right ventricular failure, subject with documented HIT or heparin-induced thrombocytopenia, life expectancy less than 1 year due to comorbidities. And one of the biggest head scratchers, because a lot of these make sense, one of the biggest head scratchers for me is the following, and this is the last of the exclusion criteria: out of hospital cardiac arrest with persistent Glasgow Coma scale of less than 8 following return of spontaneous circulation. That's a lot of patients. I suspect that perhaps a lot of patients were excluded on this, and this just what? Really? Why would we exclude out of hospital cardiac arrest patients with a low GCS? Like, this would seem to be a group of people that, if there is going to be some benefit, this would be a great pool of individuals that you'd want to look for benefit in. However, the caveat to that is cardiac arrest occurring in the ambulance, so witnessed arrest, or after arrival to the hospital is not an exclusion criteria. So essentially anybody who experienced an out-of-hospital cardiac arrest that essentially remained unresponsive following ROSC was not a candidate. That's a fairly large number of individuals who might actually benefit from this procedure, and why would they exclude them? That just really interesting. Okay, so the main inclusion criteria were age greater than 18. They had to have a diagnosis of STEMI, and they had to present with cardiogenic shock, hypotension, that's a systolic blood pressure of less than 100 millimeters of mercury, or an ongoing need for vasopressor support in organ hypoperfusion with elevated lactate greater than 2.5 milliosmoles per liter, and a left ventricular ejection fraction of less than 45%. Okay, so that's what we did. We looked at it, and they did some analyses, and their interpretation of the results is the following. This is what they essentially say: the routine implantation of the Impella on top of standard of care is superior to standard of care alone in reducing 6-month mortality. That is one of the endpoints that they looked at 6 months. And that is one of the biggest interpretations. All right. So the principal findings that these interpretations are based on are the following: the primary endpoint of all-cause mortality at 6 months, which I talked about earlier, for Impella, plus standard of care versus standard of care alone, not including Impella. And they said that 45.8% versus 58.5%. And again, this is mortality at 6 months. Let's see here. They have a hazard ratio of 0.74, which would suggest, oh wow, look at that. You know, there's a let's see, 0.74. So you're looking at a 24% decreased risk of dying. Well, this is shaping up to be pretty interesting, right? Okay, well, let's see here. Okay, fair enough. So moving on, confidence interval 0.55 to 0.99. That's at the 95% confidence interval, with a p-value of, drum roll please, 0.04. So I know this is a bit arbitrary, but generally speaking, we look for a p-value of less than 0.05 as a part of the battery of things we look at to determine statistical significance So this is just barely statistically significant. But there is more. When we compare some secondary outcomes, there are some interesting things that happen here. Some of these are not particularly surprising, but some of them are rather interesting. So when we look at sepsis with positive blood culture, 11.7% in the Impella group versus 4.5% standard of care, with a p-value of less than 0.05. Limb ischemia was also higher in the Impella group, 5.6% versus 1.1% with a p-value of less than 0.05. Moderate or severe bleeding, pretty substantial increase in the Impella group, 21.8% versus 11.9% in standard of care alone, p-value of less than 0.05. And something I find a bit compelling as well is need for renal replacement therapy, or RRT, 41.9% in the Impella group versus 26.7% in standard of care, with a p-value of less than 0.05. So this is a very interesting study for a lot of reasons. So first of all, I am seeing people, some sources are heralding this as a win, so to speak. Looking at some of the editorial comments by the authors, the results of DanGer shock are clear in that microaxial flow pump reduced mortality among selected patients. Okay. I think selection is the word of the day when it comes to this study. Let's see, one of the other authors quoted, was surprised that the benefit seems to persist beyond 30 days. So, clearly the authors are really excited about this, and other people who are looking at this seem to be excited as well. I think that there very well could be something to this, but I will say that I don't find this data super compelling. That the p-value, the confidence interval, and the fact that there are a lot of interesting, at least morbidities occurring in secondary endpoint analyses. More bleeding, more infection, higher need for renal replacement therapy. And then I think the exclusion criteria were rather interesting as well, and the fact that in my mind, a fairly large group of individuals who have cardiogenic shock, i.e. people who arrest out of the hospital, were completely excluded from this study. And that's just completely mind-boggling to me that would happen, or that there at least wasn't some sort of analysis that occurred, that it was just simply an exclusion criteria. So I think this is very incomplete, and I don't know that this is maybe as compelling as some of the individuals touting this as being compelling would suggest. But this is just kind of my personal take on the so-called DanGer shock study. I'm not nearly as optimistic, and I'm, in fact, something that has taken over 10 years to enroll all the patients, not to look at I would think a large group of individuals who may or may not benefit from Impella therapy. That just is really mind-boggling to me. So I just think this is a very incomplete study. So that's kind of where I'm at. It's incomplete. It just barely with some statistical wizardry, barely meets statistical significance in my mind, and there are some very interesting morbidities that seem to be occurring in the Impella group. And this is on top of some of the more recent controversies involving the Impella that are occurring, at least here in the United States. So when we put all this together, I don't think that this, at this point in my mind, based just on this study, I don't think this is a huge win that we really need. And I would really like to see this type of study re-examined with some different exclusion criteria to really look at what's going on and to see if this is really benefiting this I suspect fairly large group of patients. I think that would make for a much more complete picture in my mind. So that's just my humble take on the DanGer shock, or the as it is sometimes referred to, or the microaxial flow pump and infarct-related cardiogenic shock. All right, hopefully you all enjoyed this video and got something out of my cursory analysis of this newly published study. Thank you all so much. Take care.